Welcome to Module 6. This is part 2 of behavioral health and aging. And so here it builds on the previous section, and then we're going to dive into the things around depression, dementia, substance use, pain in older adults. Here you're going to recognize the signs, and then you're going to, of depression in older adults, understand dementia and the challenges that people may face in managing care, identify risks of alcohol or opioid use among older adults, and describe the impact of chronic pain on mental health and well-being. And then the later modules will figure out how we can address these things. So when we think about behavioral health, we may be working individually, we may be working with a team. And so there's a lot of individuals out there that you can, even if you're working on an interprofessional team, you can bring in other partners too. Become very familiar with effective referral relationships, and you can bring this to your clinic that you're working in. So within states, we have area agencies on aging. There's also Department of Mental Health. There's protective services. There's primary care. There's informal supports, which could be neighbors, emergency rooms. There's also things like the National Alliance on mental health as well. And then there's clergy, too, for individuals. And so you also can familiarize yourself with some different types of technologies that could actually support people who are experiencing some of these challenges. And so as we go through, we're going to talk about mindfulness and other types of things we can help people. But there's also apps out there that are free or low cost that people can use, that you can do these things together. But you can also encourage people to access technology too. So depression in older adults is not normal. And many older adults will experience, it's called subthreshold depression. So they experience minor symptoms or like just small symptoms of depression, but they're actually experiencing a major depressive disorder. Okay. And that's just part of the normal aging related process and how people present depression. So more than 2 million Americans aged 65 years or older are diagnosed with depression. But because the symptoms are so minor, a lot of people don't pick up on the actual symptoms. So true or false, depression is more common in older adults than younger people. It's actually false. More younger people are experiencing depression than older adults. So here's some of the risk factors for depression. People reporting feelings of loneliness. Again, there's that life event, death of a friend or significant other, chronic illness, and an inability to complete activities that they did once before. So here's a really cool tool. And this is about screening for depression. And you're not making a diagnosis. You're not doing anything. You're just working with an individual to find out how they're feeling. Okay. And you can take this information and provide it to the care team. And if you have informed consent, you can provide it to the caregiver to move forward in the next steps. Now, as older adults present depression in different ways, and as such as minor depression, or I talked about those aches and pains before, this is specifically designed for that older adult population. So if a person says yes to any of these questions, to more than 3 of these questions, it may indicate depression. So we don't know. It's just a screening. It's just to get the process started. So the questions are you basically satisfied with your life? Yes or no? Do you feel that your life is empty? Yes or no? Are you afraid that something bad is going to happen to you? Yes or no? Do you feel happy most of the time? Yes or no? Have you dropped many of your activities and interests? Yes or no? Do you often feel helpless? Do you feel that you have more problems with memory than most? Do you feel full of energy? Do you feel that your situation is hopeless? Do you think that most people are better off than you are? Okay, so saying yes to 3 of these, at least, may indicate depression, and so you can think about next steps for folks, which could be referral to other individuals. So let's talk about dementia. And so this is interesting because it's an umbrella term that's used to describe memory loss and impairment in judgment and social and thinking abilities. And so with this, you're going to have impaired memory, impaired language skills, impaired reasoning and judgment ability, and also impaired visual perception as well. So true or false, dementia is a normal part of aging. Well, that's false, even though more and more people are actually getting this diagnosis. So there are risk factors for the development of dementia, one of which is age. One of the major risk factors is actually mild cognitive impairment, which medical doctors use as highly predictive of actual developing dementia. Having a family history and first degree relative of a younger onset of dementia, vascular risk, so having diabetes or heart disease, low education and low physical or social activity, and female sex. So, there's some signs around this, and the earliest cognitive symptoms are having a really poor short-term memory. So, not remembering what happened in the last 10 minutes or so. And you can remember things from, 50 years ago, but you can't remember things in the last, 10 minutes or so. Okay. Then loss of orientation for individuals. Smooth, usually a slow decline with dramatic short-term fluctuations, depression, anxiety, irritability, hostility, apathy, delusions, hallucinations, sleep-wake changes, sundowning, so people become more agitated later on in the actual day, agitation, apathy, aggression, and then there's also wandering, restlessness, eating problems, agitation, disinhibition, disinhibition, pacing, screaming, hallucinations, delusions, anxiety, uncontrollable emotional outburst. Okay. So there's a lot of common problems faced by caregivers in managing older adults with dementia, and so you can be able to support people around uh, getting them the right services in place so they can address these challenges that maybe a caregiver is facing. Could be respite work to help support personal hygiene, dressing, toileting, incontinence, repeated questioning, clinging, aggression, wandering, loss of interest, activity, and hallucinations as well. So let's talk about alcohol use in older adults. So the Substance Abuse for Mental Health Services Administration, they looked at 62 million older adults, and Substance Use for Mental Health Services Administration defined this as people aged 55 years and older. And they looked at individuals between 1995 and 2002 and found that 77.5% of these older population reported alcohol use. So, alcohol was the primary substance that older adults have abused. Now, older women are more sensitive to alcohol than older men. And this is because, again, as there's normal age related changes, women will have more fatty tissue than men will as individuals are older. And so, what happens is that as people drink alcohol, it actually metabolizes slower in a woman's body versus a man's body. And then you add in the normal process of aging and a slower metabolism rate, people may actually get the negative effects of alcohol use much earlier as an older adult versus when they were 21 years old. And so if a 21-year-old man and a 21-year-old woman drank one glass of wine each, or at a certain age, at 21 years old, when they were 85 years old and they do the same thing, they're actually going to have a very different experience between those age ranges because of normal processes of aging. And if people are taking medications, it actually could strengthen or weaken the actual medication. One of the challenges related to this is falls. And remember, we mentioned frailty in older adults in previous modules. And so falls are very serious, especially if the medication side effects worsen and it actually leads to instability for individuals. So, true or false, quitting alcohol cold turkey is an effective way to treat alcohol addiction. Well, it's actually false for individuals, and it actually could potentially be fatal. So, alcohol withdrawal symptoms, it actually could include anxiety, raised blood pressure, sweating, insomnia, stomach issues, seizures, tremors, or delirium tremors, which is severe confusion. Okay. So, when you're working with this particular population, alcohol withdrawal and suddenly stopping isn't particularly effective for this group. And so you work with them and work with the team that you're working on. And if the older adult is ready to reduce their intake of alcohol, figure out a treatment plan with them in a recovery process. Now, we're going to move on to pain in older adulthood. And so, chronic diseases, as we know, and frailty can be associated with pain as individuals age. And older adults are more likely to have arthritis, bone and joint disorders, cancer, and other types of chronic disorders that are associated with pain. So, what happens there? People are actually prescribed potentially opioids to support the individual in addressing the pain. So, nursing home dwelling older adults have an even higher prevalence of pain, which is estimated between 45 to 80% compared to community dwelling older adults, which is 25 to 50% of individuals. So, opioid use in older adults, 35% of older adults have reported misusing these types of prescriptions in the past 30 days. Now, the term misusing, it could be likely, most likely related to as an older adult is taking lots of different medications because there's lots of different chronic diseases that they may have medications for. They may accidentally take an extra dose or they may accidentally miss a dose. Okay. And this is serious and severe and could lead to hospitalization and overdose because, again, as you're older, as you metabolize things, it actually the process slows. So if an older adult accidentally took two opioids when they're only supposed to take one, there's so much of the opioid in the system it actually leads to an overdose and potential death. So it's a very serious challenge for individuals. I'm going to talk about how to address that. So in 20 years, the rate of hospitalizations for geriatric opioid misuse has actually increased fivefold. And so this matters so much because it actually could lead to sedation, depression, impairment in vision, attention, coordination, as well as and then death for individuals too. And the side effects of opioid use disorder can lead to increased hospital use. And just so folks know, older adult opioid related use of hospital and treatment center increased dramatically from 2005 to 2014. So there are signs of opioid overdose. And you may have seen what somebody has looked like on this opioid overdose. And it could be actually pretty difficult recognizing the signs could be difficult. There's a few things to look out for when you're working with an older adult. So it could be unconsciousness or unresponsiveness, shallow breathing or even no breathing, and then pinpoint the pupils as well. So if you suspect someone is overdosing or in distress, you can call 911 and or seek immediate medical care. Some of our colleagues in supportive housing, they may have a Narcan available within the housing facility as well. So something to be aware of. And peers now are actually carrying Narcan as well to help support this population. But no, it's also with older adults and not just younger adults. And a lot of it is not intentional. So true or false, pain is a natural part of growing older. What do you expect? You're just getting old. Well, that's false. It's not a natural part of getting older, but it does impact an individual's lifespan, and there are some things that you can do to help people with the experience and management of pain, and we're going to get into that in later modules. When we're working with an older adult about pain, we need to think about the stereotypes around their expectations and perspectives, and really what constitutes like successful treatment. So research shows that many patients often wish to discuss, well, lifestyle changes and non-medical approaches to pain because there is a fear of taking opioids, and it's what is generally prescribed to this particular population for the pain that they are experiencing. So there are opportunities for behavioral types of interventions. So for one thing we can do is education. So avoid taking prescription painkillers more often than prescribed. Encouraging people to dispose of medications properly as soon as the treatment is complete. And this helps people not accidentally take some when they don't need to. You can store opioids in a secure place where others cannot get them. And you can also help too by not selling or sharing prescription medications with other individuals. We can educate people on this. People can access a treatment locator around these challenges. And there's a number there for the Substance Abuse and Mental Health Services Administration. Then you can also call it Poison Help as well for questions about this medication. So, medication is one opportunity. Non pharmacological approaches to pain or behavioral approaches are, well, educating the service user and the caregiver of the individual. Regular physical activity can help offset pain. It could be things like yoga or Tai Chi, and these programs are offered through area agencies on aging. You can help coordinate with a psychologist or a social worker to offer cognitive behavioral therapy. For some individuals, you can refer them to the clergy if it's appropriate. There's also self management training as well. So, self management is teaching people the skills necessary to help them with having a healthy lifestyle, diet, exercise, to help them take care of themselves as they support one another. Then also older adult peer support and the Supporting Other Adults Remotely program, as we'll work with people to show you how you can work with people step by step to help offset pain in individuals.